Hi, my name is Tammy Lee. I'm a pharmacy resident here at UC Health Poudre Valley Hospital. Today I'll be talking to you about picking targeted therapy in advanced breast cancers, alpelisib piqray. I want to disclose that I have no conflicts of interest. And here are the objectives for this presentation outlined here for your review. So let's start off with a patient case. Our patient is a 67-year-old white female with stage 4 metastatic breast cancer, hormone receptor positive, HER2 negative, BRCA negative, and PIK3CA positive mutation, presenting to clinic for follow-up. She has imaging that reveals progressive breast cancer while on abemaciclib. Patient has a palliative intent and an ECOG performance status of 2. Her pertinent past medical history for this presentation includes a stage 4 breast cancer, type 2 diabetes, and history of VTE. She has a strong family history of breast and ovarian cancer as well, seen in her mother and sister, and she was a former smoker, quit in 2014, and denies any alcohol use. Our patient has a wide oncologic treatment history. For the purposes of these next few slides, just know that the majority of the treatment discontinuations or stops were either due to a disease progression or toxicity. In December of 2006, our patient was diagnosed with stage 2A infiltrating ductal carcinoma with positive nodes. In January of 2007, she started on aromatase inhibitors and anastrozole, then switched over to letrozole due to toxicity, underwent a lumpectomy, FEC regimen, and radiation. In April of 2009, aromatase inhibitors were deferred by the patient due to its toxicity, and in April of 2014, on a breast screening MRI, she was diagnosed with recurrent breast cancer and underwent a bilateral mastectomy later that year, and started on exemestane, however stopped due to bone metastases being diagnosed. In January of 2015, capecitabine was started and stopped, then transitioned over to weekly paclitaxel in December. In July of 2016, paclitaxel was stopped due to toxicity and disease progression, which then she switched over to palbociclib and fulvestrant. Our patient was maintained on palbociclib and fulvestrant for a couple of years until January of 2018. That was stopped due to multiple admissions from its toxicity and a new hypermetabolic spot found in the liver. In April of 2018, eribulin was started, then that was stopped and switched to gemcitabine, and then that was stopped, switched to everolimus exemestane, and then that was stopped due to disease progression, which then she switched over to doxorubicin and dextrosane, which was also stopped from toxicity and progression. Then nab-paclitaxel or Abraxane was started and stopped, which brings us to our most current time frame of abemaciclib, which during this chart review, she was currently on abemaciclib, however, was being considered to discontinue this treatment due to its toxicity profile as well. Also, during this year, in August, she underwent PIK3CA mutation testing and found that she was PIK3CA positive, which brings us to our most current, August 2019, where she was about to start alpelisib and fulvestrant, and brings us to our topic of discussion today. Our patient has multiple current home medications. However, for this presentation, the pertinent ones were the abemaciclib, her insulin and metformin for her diabetes, and then her warfarin for her history of VTE. There's some background about cancer and seen in this slide for your review, but it is the #1 cancer in the United States. Its highest prevalence are in non-Hispanic whites and blacks, and there's a high risk with the family history of it as well. Risk factors include gender and age, such as females, and also can be found in males. The median age of diagnosis is 62, and of those diagnoses, 62% have been localized, 30% are regional, 6% are metastasized, and the overall 5-year survival rate is about 90%. So what do we have for treatment options for our stage 4 breast cancer like our patient presents with? As you can see here, this is taken directly from the 2019 NCCN guidelines for HER2 negative and postmenopausal breast cancers. As you can see, our patient had been on multiple of these regimens, such as the aromatase inhibitors and activators, also capecitabine, paclitaxel, then also fulvestrant, CDK4/6 inhibitors, eribulin, then she was switched over to gemcitabine, and then exemestane, everolimus, doxorubicin, albumin-bound paclitaxel or Abraxane, and the most current abemaciclib. So what else is there to try in our patient? Well, you can see in the highlighted yellow, there is also fulvestrant and alpelisib for PIK3CA mutated tumors or PIK3CA mutations. There are 4 different breast cancer subtypes. There's hormone receptor positive and HER2 negative breast cancers are the most common, around 71%. Of those, 40% of those specific subtype breast cancers have the PIK3CA mutation. The PIK3CA mutation is not only found in breast cancers, but can be found in about 25% of all types of cancers. There's a known link between the PI3 kinase pathway and cancer. Not until recently did we have specific drugs that could target genes within this pathway. The PIK3CA gene, or the PIK3CA gene, encodes for the P110 alpha protein of the PI3 kinase. This P110 alpha protein is the catalytic subunit for the PI3 kinase pathway, which activates this pathway. So PI3 kinase is important in cell growth, proliferation, differentiation, and motility and survival. Thus, if we have an altered catalytic subunit, such as the P110 alpha catalytic subunit, we have unregulated PI3 kinase signaling, leading to uncontrolled cancer cell growth. This mutation is somatic and an activating mutation. Somatic as in it doesn't happen in the germ cell line, it happens after DNA and after conception. And it is an activating mutation because it activates the PI3 kinase pathway. This mutation can be found in, like I said earlier, not only breast cancers, but can be found in ovarian, lung, or brain and stomach. The PI3 kinase ACT-mTOR pathway is an important pathway for protein synthesis and cell cycle activation. Not only can this pathway be responsible for uncontrolled cancer cell growth, but is essential for our body's normal function, such as glucose uptake, which I'll talk a little bit about later. Of note, this image represents a very simplified view of this pathway. In reality, this pathway is way more complex than depicted. When a growth factor, such as IGF, EGF, or VEGF, binds onto growth factor receptors on the cell surface, as you can see circled in red, binds to that growth factor receptor, this activates the PI3 kinase pathway. PI3 kinase is actually made up of 2 subunits, the P85 or regulatory subunit and the P110, which we talked about earlier, which is the catalytic subunit. That subunit is responsible for phosphorylating PIP2 into PIP3 to activate this pathway to be able to affect downstream. So that PIP3 then activates ACT. ACT is important in protein synthesis and also inhibits tumor suppression and cell apoptosis. ACT also plays an important role in survival and proliferation and differentiation of the cell. ACT can also work downstream on mTORC. mTORC is also important in protein synthesis. So as you can see here, if we have an unregulated and activated and overactivated PI3 kinase pathway, we have more unregulated and unwanted cancer cell growth. It is important to note that this pathway is responsible for taking in glucose into the cell. As you can see, IGF, or insulin growth factor, circled in green, actually binds onto these growth factor receptors on the cell surface. Once internalized, it activates this PI3 kinase pathway, which allows for glucose transporters inside the cell to be brought onto the cell surface to take up glucose from out of the cell. However, when this pathway is suppressed or inhibited, this does not allow for those glucose to be taken up into the cell, which leads to one of these side effects of hyperglycemia in this drug class. As you can see, when a PI3 kinase inhibitor blocks all these parts of the pathway, we have less cancer proliferation and PI3 kinase signaling. Alpelisib, or Piqray, was approved earlier this year in May of 2019. It's manufactured by Novartis. It's a PI3 kinase alpha isoform selective inhibitor. It's indicated with fulvestrant for men and postmenopausal women with hormone receptor positive, HER2 negative, and PIK3CA mutated advanced breast cancers following the progression after endocrine treatment. It does come in different oral film-coated tablets, but the dose starts at 300 milligrams daily with food. So the SOLAR-1 trial was a phase 3 randomized, double-blind, placebo-controlled trial that brought this drug onto the market. It looked at alpelisib and fulvestrant versus placebo and fulvestrant. A total of 572 patients were taken and divided into 2 different cohorts, the PIK3CA mutated cohort or the PIK3CA non-mutated cohort. The primary endpoint was looking at median progression-free survival in the PIK3CA positive mutations. Other secondary endpoints for this presentation include overall response rate, progression-free survival of those PIK3CA negative or non-mutated cohorts, safety, and clinical benefit, as defined as complete or partial response or stable disease for greater than or equal to 6 months. So So the study design looked at, I said earlier, the two different cohorts, those with the mutation and those without the mutation. They randomized those 1-to-1 stratified by the presence of liver lung metastases and prior CDK4/6 inhibitor treatment to receiving alpelisib plus fulvestrant or placebo and fulvestrant. Of note, I just want to bring your attention to some of the exclusion criteria listed below. They did exclude type 1 diabetics or uncontrolled type 2 diabetics as defined as a fasting plasma glucose of greater than 140 or an A1C of greater than 6.4%. Also, patients enrolled in this trial had an ECOG performance status of less than or equal to 1. So the key findings from the SOLAR-1 trial investigators found a clinically relevant treatment benefit in those patients with a PIK3CA mutation. Progression-free survival almost doubled at 11 months versus 5.7 months in the drug versus the placebo. There was, however, no benefit in those without a mutation. The overall response rate and clinical benefit rate were greater in the arm receiving alpelisib. This slide shows the Kaplan-Meier curve for the PIK3CA non-mutated cohort. There was no significant progression-free survival at a hazard ratio of 0.85. Proof of concept criteria was not met in the PIK3CA non-mutated cohort, thus confirming lack of clinical benefit. This is the Kaplan-Meier curve for the PIK3CA mutated cohort. As you can see here, the hazard ratio of 0.65 was statistically significant, and there was a difference in progression-free survival in alpelisib and fulvestrant versus placebo and fulvestrant, favoring alpelisib fulvestrant for a longer progression-free survival. In addition, the SOLAR-1 investigators also looked at the subgroup analysis of PIK3CA mutated cohort. As this flourished plot shows, there is a favorable treatment effect for alpelisib consistently across almost all subgroups. This includes patients with or without prior treatment for advanced breast cancer and prior CDK4/6 inhibitor use. I want to draw your attention to the previous CDK4/6 inhibitor use. As you can see, only 20 patients in this cohort did receive it. Due to the limited number of patients in this cohort who would actually receive CDK4/6 inhibitors prior to treatment, there's an unclear significance for this subgroup. Which leads us to the BELIEVE trial, which is a phase 2 study of alpelisib and fulvestrant, or an aromatase inhibitor, depending on what the patient failed on previously, for hormone receptor positive, HER2 negative, PIK3CA positive advanced breast cancers. It aims to look at patients and the sequencing of patients receiving alpelisib after progression of a CDK4/6 inhibitor plus endocrine therapy. This aims to answer those questions and concerns about its sequencing. So, as you can recall, the 2019 NCCN guidelines outline both fulvestrant CDK4/6 inhibitors and fulvestrant and alpelisib for PIK3CA mutations as preferred regimens in patients with advanced breast cancers. That leads us to this clinical conundrum of what should we use in this patient population. Here's an informational slide which I've summarized the progression-free survivals and overall response rate for CDK4/6 inhibitors currently on the market and currently being used. These trials are specific for hormone receptor positive, HER2 negative advanced breast cancers after progression on endocrine therapy. As you can see, these drugs show similar durable response rates and progression-free survival as alpelisib does. Since there's no head-to-head trials of these targeted therapies, especially against PI3 kinase inhibitors, it's unknown to which is superior. This may lead to clinical controversy when selecting a regimen in this patient population, and no one drug is perfect and without its adverse effects, so ultimately it'll be up to the patient and the provider to choose a regimen appropriate based on patient-specific factors. This which brings us to our first self-assessment question. Which of the following is incorrect? Is it A, alpelisib targets the PI3 kinase ACT-mTOR pathway? B, alpelisib and fulvestrant significantly improves PFS or progression-free survival compared to placebo and fulvestrant? Is it C, alpelisib therapy should be given with fulvestrant? Is it D, alpelisib is beneficial in patients with wild-type PIK3CA non-mutations? Correct. The answer is D. Alpelisib is only beneficial in patients with PIK3CA positive mutations as seen in the SOLAR-1 trial. When looking at the safety for the SOLAR-1 trial, almost 100% of patients in the alpelisib fulvestrant arm experienced an adverse effect. Of these adverse events, 76% were grade 3 or 4 and were higher compared to the grade 3 or 4 adverse effects experienced in the placebo and fulvestrant arm at 35.5%. The bottom half of this chart shows you the different types of adverse effects leading to discontinuations of the study drug. Discontinuations due to adverse effects were highest in hyperglycemia, rash, and diarrhea. Discontinuation due to disease progression were greater in the placebo arm at 68% versus 55%. The most common adverse effects were hyperglycemia, diarrhea, nausea, decreased appetite, and rash. Since hyperglycemia was a top adverse event leading to the most treatment discontinuations and most side effects, I wanted to spend some time talking about hyperglycemia management. As I mentioned briefly about the importance of PI3 kinase and glucose uptake into the cells, the hyperglycemia of alpelisib is an on-target effect. When insulin growth factor couldn't bind onto the growth factor receptors to activate the PI3 kinase pathway, that blocked the glucose transporters from being put onto the cell surface to bring in glucose from outside of the cell into the cell, thus leading to more free-lying extracellular glucose and hyperglycemia. However, this adverse effect is reversible and easily identifiable. It's important that we can provide dietary management and early pharmacologic interventions for our patients taking this drug. It's important to screen and monitor glucose levels in all of our patients. We want to optimize glucose control prior to initiation. As we saw earlier, one of the exclusion criteria for the SOLAR-1 trial was uncontrolled type 2 diabetes or excluded type 1 diabetics. We want to get a fasting plasma glucose level at baseline within the first 2 weeks and then at least monthly. We want to get an A1C level at baseline as well. We also can consider dose-reducing alpelisib for patients who experience a grade greater than or equal to 3 hyperglycemia. Here's a slide with the information of the CTCAE adverse event grading for hyperglycemia. As you can see, the grades of hyperglycemia go from 1 to 5, 5 being the most severe and 1 being the least severe. When managing the side effects of hyperglycemia due to alpelisib, we want to manage based on grades of hyperglycemia. For grade 1, we want to maintain the dose level. If the fasting plasma glucose is less than 140, we want to consider adding metformin. However, if it's between 140 to 160, we can start or intensify the metformin. If it's a grade 2 hyperglycemia, we want to maintain the dose level. Then we want to titrate metformin to its maximum tolerated dose in 3 weeks. If it's persistently rising or above 160, then we want to add pioglitazone. And in 21 days, we recheck, and if it's still a grade above 2, then we want to reduce by 1 dose level. If it's a grade 3, we always want to confirm fasting status of that level, and we want to hold treatment. We want to give appropriate IV hydration and clinically appropriate interventions as necessary. We can titrate the metformin and add pioglitazone. We give insulin for a few days, and then in 3 to 5 days, we recheck that level, and if it's still a grade less than 2, we can reduce the dose level. However, if it's grade greater than or equal to 2, we consult endocrinology. In 21 days, if that grade is still above 2 or more, then we want to discontinue this drug permanently. For grade 4, we also hold treatment. We want to intensify or initiate antidiabetics as needed and recheck fasting plasma glucose in 24 hours. If that grade improves, we can follow grade-specific recommendations. However, if the grade is still greater than 3 or more in 24 hours, then we want to discontinue the drug permanently. In addition, gastrointestinal toxicities such as diarrhea and nausea were common in the SOLAR-1 trial and in patients taking alpelisib. It's important we can counsel our patients to take this medication at the same time daily and immediately after food. For patients with diarrhea, we can also give self-administered antidiarrheals such as loperamide. On the right-hand side of this chart, I've listed different grading criteria for diarrhea. If it's an uncomplicated grade 1 or 2, we can easily manage it with antidiarrheals. If it's a grade equal than or greater than 3, which is medically complicated as well, we can consider a more aggressive approach such as the treatment interruption or dose reduction in addition to loperamide. Our Beacon order set here at UC Health actually adds in loperamide as a take-home medication for patients taking alpelisib. In addition, for nausea, we want to follow a standard antiemetic guidance and also counsel on adding dietary changes as needed. Patients also can experience a rash with alpelisib, so prophylaxis with an antihistamine can be considered. It is shown to reduce the incidence and severity of the skin toxicity. Cetirizine 10 mg tablets are actually built into our Beacon order set as a pre-medication. For the treatment of rashes, we can consider using a topical steroid or an antibiotic, topical or oral depending on its grade. And also we can consider holding alpelisib or doing a dose reduction for resistant cases of rashes. When we talk about dose modification for adverse effects, like the dose reductions, we always start at the 300 milligrams once daily and reduce by 50 milligrams until we hit 200 milligrams, and if we needed to reduce any further, we would actually just discontinue alpelisib altogether. This brings me to my second self-assessment question. What is the most common adverse reaction to alpelisib? Is it A, alopecia, B, neuropathy, C, hyperglycemia, or D, neutropenia? Correct, the answer is C, hyperglycemia. Drug-drug interactions are also known with alpelisib. Alpelisib is a substrate, inhibitor, and inducer of those enzymes and transporter listed on the slide. It can have an effect on other drugs, such as CYP2C9 substrates. Alpelisib can actually decrease those concentrations by inducing CYP2C9. Other drugs can have an effect on alpelisib, such as CYP3A4 inducers, which can decrease alpelisib's concentrations, leading to a decreased efficacy in alpelisib. Also, BCRP inhibitors may increase alpelisib's concentration, which is an efflux transporter, so something that blocks a BCRP efflux transporter can increase the toxicity levels of alpelisib by not allowing its efflux. So in these cases, we want to avoid these types of drug-drug interactions. Here's a nice slide which shows you the examples of potential drug interactions alpelisib might have. It shows you CYP2C9 substrates, BCRP inhibitors, and CYP3A4 inducers and inhibitors. These are common drugs we should look out for as pharmacists, and to know if the patient is taking any of these drugs, they may interact with alpelisib. So back to our patient case. Our patient had multiple drugs that had an interaction with alpelisib, but the most substantial ones were warfarin and for her anti-diabetic medications. Warfarin is a CYP2C9 substrate, so alpelisib may actually induce this CYP2C9 to decrease warfarin's efficacy. So we want to recommend increased INR monitoring, and luckily for our patient, she was followed regularly with the anti-coag clinic, and we did also notify the anti-coag clinic of this new drug interaction. Here's her recent INRs listed. As you can see, they were kind of fluctuating, so we want to keep a closer eye on her. For diabetes, as we know, hyperglycemia is the most common adverse effect, and even the SOLAR-1 trial has stated that there was limited guidance with diabetics, and it's not well studied in the SOLAR-1 trial. In addition, the package insert states that guidance on patients taking alpelisib with diabetes is not well known. So it's recommended that we always increase our surveillance of her and increase the doses of anti-diabetic medications if possible to keep her blood sugars well under control. Her baseline A1C was recommended prior to starting therapy and looked like her A1C was 7.1, and her glucose was 226. We tried to get a fasting plasma glucose on her, but her appointment was later in the day, so we were unable to do so. So following up with our patient, these were the sequence of events that happened after initiation of alpelisib therapy. On 8/19, alpelisib was started. The following day, the patient called their oncologist with a random blood glucose of 495, and she was asymptomatic. The oncologist was made aware and sent her for urgent referral to primary care. The next morning, the primary care followed up via telephone, and the patient still had a blood glucose high in the 600s that night, last night, and in the morning. She felt like she was shaking like a leaf. She had weakness, thirst, and confusion. The primary care pharmacist instructed the patient to use insulin and to go to the emergency department as soon as possible. The patient gave herself insulin and arrived to the ED with a blood glucose of 384. Meanwhile, all of that was happening. Our oncology team was made aware, and the oncology pharmacist recommended to hold alpelisib, increase her metformin to 1 gram twice daily, consider adding pioglitazone, to increase her insulin scale, and send her for an urgent endocrinology consult. Later that day, her alpelisib was held. She was referred to endocrinology right after the ED. She visited them, where they adjusted her insulin scale, as well as they also gave her an increased dose for metformin. On 8/25, the patient returned to the emergency department, but this time for dehydration, and her blood glucose was found to be 201. On 8/25, she returned to the emergency department, but this time for dehydration. Her blood glucose was found to be in the 200s. Later that day, she spoke with the oncologist, and on the next day upon chart review, we found that the patient requested to discontinue her medication, or alpelisib, because she was frustrated with the side effects and requested for hospice. As you can see, our patient had been through a lot, from her previous regimens, toxicities, progression, and a new drug that had added multiple ED visits, office visits, and most likely decreased her quality of life and increase her cost of care, I really don't blame her for her frustration since this caused a lot of problems for her. So it's really important to keep in mind for our patients with a palliative intent that we want to make sure we're not doing more harm than good. As you can recall, this slide that I showed you the management of hyperglycemia based on hyperglycemia grades might actually not be applicable to every patient, especially to patients who are diabetics because they were excluded in those trials or not well studied in the trials. So sometimes we might have to take this with a grain of salt and use our best clinical judgment because not every patient is going to be able to follow this flow sheet, especially in this case of our patient. So this brings me to my last and final self-assessment question. What kind of drug is alpelisib? Is it an A, VEGF inhibitor, B, CDK4/6 inhibitor, C, PI3 kinase alpha inhibitor, or D, PI3 kinase gamma inhibitor? Correct, it is C, a PI3 kinase alpha specific inhibitor. In summary, alpelisib or Piqray is indicated with fulvestrant in patients with hormone receptor positive, HER2 negative, and PIK3CA positive advanced breast cancers following the progression after endocrine treatment. And it targets those tumors by inhibiting the intracellular PI3 kinase pathway to decrease cancer cell proliferation. Alpelisib has been shown to nearly double the progression-free survival compared to placebo, but the most common adverse events include hyperglycemia, diarrhea, nausea, and rash. Patients taking this drug should be followed closely for adverse effects and monitored for drug interactions. Here are the references, and I hope you enjoy picking targeted therapy in advanced breast cancers, alpelisib and Piqray.